for some reason are unhappy and wander into my office. But I'm also comfortable with open surgery, doing about 50 arthroplasties a year. So our first thought was fixed the labrum. So we have Murray Wiley's rivet here in the late 70s, Landy Johnson staple, then a screw because the staple got loose, and then we have some tacks, and all sorts of tacks came on it. They became popular and floated around the joint. And then we had various types of suturing operations, from the Casperis to et cetera. And then we had the suture anchors. Here's a metal early Mitec, and now we have many different anchors and materials and et cetera. So now, here we are 27 years later. This is a report out of New York of 83 patients. We heard about this earlier. Now, the people under the age of 20 had a 37.5% recurrence rate. And their conclusion was patients under the age of 25 with ligamentous laxity, Hill-Sachs, were at the greatest risk, and you should have counseling and consider open stabilization. Now, the knock on perhaps this group is they didn't do inferior sutures, similar to what Dr. Pedowitz just showed and what Ben Schaefer showed earlier. So why do things fail? Well, you can have the wrong diagnosis, wrong surgery, inadequate surgery, or just under the philosophy not all surgery works, and that's the way it is. So here's a patient with failed instability surgery. He's a 28-year-old male policeman. He had a recurrence after a scope repair. You can see that he's got anterior bone loss, and he has a large Hill-Sachs lesion. And then that person, I did a ladder J procedure. So we have bone, ligaments, cuff, and then the patient's activity level. So if hopefully all my patients will become slugs and they won't dislocate again. And then we have to remember the original dislocation event and attention both to the humeral and glenoid side. So now when people show up in the office, they're either loose or stiff. So there's a group of people that are stiff, and that's their problem. What their activity level, what arm position, and then does it feel unstable? And then I'm sort of a stickler for trying to find the previous op report, what was done to the ligaments, to the cuff if they had open surgery, whether the subscap was taken down, and then the bone and humeral loss. And then examination under anesthesia would be their range of motion, stiffness, and can I produce anything with apprehension? And that slide is hidden. And then I do radiographs, and here you can see we're losing, there's some bone loss anteriorly, and that's I think this 3D CT at least enables somebody like me that doesn't like to measure a lot. It's obvious that there's a defect there. We can also have anchor arthritis. Here's a person that has some nice bioresorbable, at least allegedly, anchors in the front of their glenoid, and now they're failed, and you can see that they have arthritis and they're under 30 years of age. So I'm seeing a lot of these patients. So we're not only dealing with loose people, we're dealing with bad problems. So I mentioned the instability can be due on the glenoid side or the hardware stiffness on the right slide. Now, if we go look at it differently, we can look at the surgeon and then the anatomical factors on the right. And as a surgeon, we have to decide, do we make the right diagnosis, and do we do the correct treatment, or was there a technical problem in what was done? Now, this is a woman I saw last week. Back up, coming back. Oh, that slide. Anyway, that slide goes to full. That's all right. This lady's 25. She had two previous surgeries, one 5 years ago, one 2 years ago. First one was some sort of scope repair. I couldn't find a report. Second one, she had two suture anchors put in place. There's no mention other than the patient had instability. So I examined her in the office, and she had full range of motion. All she did is said, my shoulder hurts, it doesn't dislocate. I took some x-rays. And then finally, here's some laxity testing, and obviously we're going to operate on her. Finally, I said to her, well, how does this thing go up? Because I tried all of the different load and shift maneuvers, and I thought it was pretty good on posterior instability. And you can see she's got some laxity. And I said, well, show me what happens. And you can see with horizontal adduction, she's a voluntary posterior dislocator. Yet she's had two operations, and nobody's seen that, and she doesn't walk around saying I dislocate. And I just got lucky I couldn't figure out what was wrong with her. We're saying, well, show me how it comes out, because I couldn't elicit that. And here we see that the bone loss is the primary cause, and then Dr. Wolf likes to do the remplissage, and that's just dealer's choice. So bone losses are common. Here's just a couple quick slides. You can have a lot of glenoid defects, humeral defects. Biomechanically, glenoid bone loss reduces stability, and the humeral defects are associated with all these patients unless they have the MDI that Dr. Pedowitz talked about. Now here's a person I repaired this guy. He went to UCLA. He went to a summer baseball camp, dislocated his shoulder 5 years ago. I did a Bankart repair, and I thought I really fixed him fine. Then he comes back to me in the surgeon's lounge and says, my shoulder still slips out, and I start to examine him. He said, don't touch my shoulder. I don't want you to do anything. And you can see he's got a big Hill-Sachs lesion. His glenoid looks good. And so I'm thinking, well, what am I going to do to fix this guy? And then his next question out of his mouth is, how long after surgery will I be able to play sports? So I just told him that he'd better just live with it, because I didn't know if I could fix him. So he's happy not to do anything except be apprehension. Interesting, his kid dislocated his shoulder, and I fixed him, and he hasn't dislocated lately. Dr. Wolf alluded to this report by Burkhardt and De Beer showing that if there was no bone defect, then there was a very low recurrence rate. So the clinical clues I use, the people who come in and say, my shoulder dislocates when I sleep, and they may be 35 and have a repair, I begin to look at them for bone deficiency. Now, I think this is one of the most important papers recently that most Americans, I find, are ignoring this. So Pascal gave people a point according to whether they were under 20, competitive, which is obviously if you're a jock doc, these are the people you see, some bone loss. Okay. Go back one. Here we go. Now, he said if the people have a score over 6, they had an unacceptable recurrence rate. He also pointed out this hyperlaxity, both in external rotation and also putting your arm here and elevating the shoulder. And if they had this glenoid defect plus laxity, they had a 75% recurrence rate. So I think you need to share this with your patients, and they may not do as well as we would like to think. And then he felt if his score is greater than 6 points, they thought an arthroscopic repair is contraindicated. Now that, you may just decide these are a bunch of crazy Frenchmen, although we heard Gene, and he's a Frenchman too. And then this is some of Pascal's points, the difference between a small Bankart here, bony Bankart, and then attrition. Here's a case of this person had an anterior dislocation with a seizure 7 years before. He had an open repair. He dislocated on a cruise playing basketball, and he said, I want you to treat me arthroscopically, and I couldn't dislocate this guy in my office. I couldn't do anything. His x-rays look pretty bad. You can see he's got a huge Hill-Sachs here. So I decided I would take him to surgery and just see what I could do, because he wouldn't let me do this in the office. And you can see he's out, and now he's out there, and then he slips back in. So this kid was really unstable, and I just quit right there and did an open procedure on him. I just didn't feel I could fix him arthroscopically. So my next step was a bone block. I think Dr. Wolf's would have been to do a remplissage, but I'm putting words in Eugene's mouth. So again, this guy was recreational athlete playing basketball. He had hyperlaxity, he had a Hill-Sachs glenoid. This would be a 7 on Pascal's score. If you look at some outcomes, here's a report from Shoulder and Elbow in 2007. These are people that had previously failed surgery. They had 24 patients. 8 decided not to be operated on. 16 had surgery. Of those, 8 had a further recurrence. So the outcome of these people, if you don't address their bone, is pretty high. And this, again, is Tim Malone's. And I think the point in Tim's article, Tim was a Navy guy in San Diego where Matt Provencher and some of the other people are, and they have like 30 people on their list waiting for Bankart surgery. And his point was that people with a bony Bankart that he repaired were different than the attritional bone loss. So I think you need to look at these people differently in your approach. And again, this is Timmy's showing the attritional, and then the bone. Dr. Sagaya has shown you can repair these. So I think these are two different animals, and this would be a drawing with the ligaments. Now here's another report of people with revision failed surgery, and 4 patients had a recurrent instability. Their WOSI scores weren't the greatest, but he felt there was a satisfactory outcome, again, if there's not a large Hill sac. So I would pay attention to the bone. Here's another case. This person works in a sawmill. He had a skateboard dislocation. He had previously an open repair, and he had a Hill sacs. You can see he's got a defect. This doesn't look the worst here. He's got a little Hill sacs. Well, that's actually a case where he operated. Amazing it didn't show well. And we fixed that guy, and he actually has done very well. Here's a 39-year-old writer, and I'm always, I don't know if you're in L.A., and I live in Oceanside, so thank God I don't live in L.A., but they have a lot of unemployed writers that show up, and they're like 38 years old, and their shoulder dislocated at night. He had an arthroscopic repair 5 years ago, and you can see that he doesn't have much there at all. So I did a bone graft. Here's a coracoid transfer. And at this time, I was doing the Burkhardt de Beer, where you put some anchors in the native glenoid and repair the capsule. I don't do that anymore. I do the Gilles Walsh's way. And I hope that my bone doesn't look like that. I think some of that is the screws. Now here's another kid. This is a 17-year-old high school linebacker. Since I'm a big sports doc and this kid was in high school, I fixed his shoulder with 3 anchors when he was a junior in school, and he did well the next season, then dislocated in the spring. And you can see, you would say he's under 20, competitive, contact overhead. He had a Hill sacs. His glenoid initially didn't look too bad, so he has a 0.6. So now I decided to get a CT scan on him because I figured out how to do that test a few years ago, and you can see he's got a hatchet glenoid. So I think he has anchors here, and then what happens is they just fracture this glenoid. So in this person, I actually did a Latarjet, and then that looked pretty wimpy, and then I also did an iliac crest bone graft. Here's his native glenoid. He's 2 years post-op now. He's stable. Fortunately for me, he's a Mormon missionary, and he's finishing that up, and now he plans to go back to college, so we'll see how this holds up. Here's a couple last cases that run into my office in terms of what we're doing or what we think we're doing. Here's a 29-year-old fireman. 2 years ago, he had a scope, he had an anchor, had a pain pump, and now his joint's kind of worn. We did this hemicap, and now he can get his arm up to about 100 degrees. He has much less pain, but he's not perfect. Here's a 29-year-old ex-college swimmer. 8 years ago, she had thermal and a pain pump on her report, and I'm going to do a total shoulder on her in about a month, but this is what her joint looks like. So the stuff we do isn't benign when you look at instability and things that are coming down the pipe. So my conclusion at this point in life is failed instability surgery is most likely due to glenoid bone loss and the humeral side. And this is a difficult problem for me, and these are difficult patients. Often they're kind of angry and annoyed at their previous physician. You have to just calm them down a little bit and point out that this is just the way it is, and how are we going to move on from there. So thank you for listening to me, and for Ben for inviting me.